Welcome to Greenville, South Carolina. It's early, it's rainy, but don't worry, because we're going to talk about macular degeneration and really start this party off, all right? Yeah, and not just any macular degeneration, dry macular degeneration, right? I think they strategically placed me in the order of events right at about the time the caffeine should be hitting, so which actually is probably pretty smart. But believe it or not, there are some exciting things happening in the world of dry macular degeneration, and I'm going to try to convince you of that as we go through this discussion. I don't know if this thing's working. All right, cool. I don't have any relevant financial disclosures to make. I am a principal or primary investigator in our clinical trial site for some of the studies, some of which we will discuss later on in the talk. So we're going to talk a little bit about where we have been historically, where we are currently, and very briefly at the very end, a little bit about where we're going. So macular degeneration is a big problem worldwide. Apparently it is the third leading cause of vision loss globally. Our minds are on the Olympics right now. I guess we win the bronze medal for vision loss. But in industrialized nations, it is the primary cause of blindness. So I think first and second place globally, cataracts and glaucoma. But here we are very good at repairing those, or at least managing those, but we still aren't that great at managing macular degeneration. As we all know, the population is only aging, which then can lead to increased numbers of incidents of macular degeneration. Macular degeneration is classified into two forms, as we all know, dry and wet. The dry being characterized by drusen, PEDs, as you can see there on the left, and of course the wet with choroidal neovascularization, disciform scarring, subretinal, intraretinal fluid, and of course in this situation, very bad situation, subretinal hemorrhage, leading to pretty rapid vision loss. OCT of the dry macular degeneration, characterized by drusen, as you can see at the top. This is a good example of progression of dry macular degeneration from really at the top not too bad drusen, and then as you move down to the middle image, and you can see the near infrared on the left, that white lesion to the side, representative of geographic atrophy, and in the raster cross section you can see that transillumination defect of RPE loss, and then at the bottom you can see how much that can progress. And geographic atrophy is the main cause of vision loss in dry form of macular degeneration. I think there's a delay here, I don't know. Oh, there we go. Fundus autofluorescence is becoming more and more utilized in monitoring for progression of this geographic atrophy. You can see this is a different patient, but these areas of multifocal hypoautofluorescence in these dark circles that you can see in the left are non-subfoveal or in the parafoveal region, but can progress in the other eye to become more of a foveal involving RPE loss, and that is, obviously due to lipofuscin loss and loss of the RPE structures, which then results in photoreceptor loss. Wet macular degeneration is characterized by fluid, obviously, hence the name. You can see in the top picture the subretinal fluid, also intraretinal fluid adjacent to that, and the resulting subretinal fibrosis and fibrovascular PED, which we have become pretty adept at managing with injectables. In the bottom picture, that's the result of the same eye status post an anti-VEGF injection. And for that reason, for the past 20 years, we have had a significant focus on wet macular degeneration with very good outcomes. You can see historically, we got PDT, let's not forget about that. It's still utilized some, not much, but started that. I guess even before that, we had the macular photocoagulation studies, which was not the greatest way to manage wet macular degeneration as we know, but moving forward into the anti-VEGF era, you can see how many there are. And you can't turn on a TV now without seeing commercials about some of the newer medications that are coming out. And the reason is obvious. Again, a great example of one of my patients here who walked in. He'd actually lost vision in his other eye to disc-form scarring from wet macular degeneration. We've been monitoring his good eye for years, and he walked into my clinic, this was probably 3 months ago, and said something's wrong. And you can see he had new subretinal fluid, SHRM, and significant vision loss from 20/20 to 2100. And with just a single injection, improved 1 month later to 20/40. Still a little bit of fluid lasting, but in follow-ups, as we have utilized these medications more, he's now back to 20/20, and he's super happy, which is awesome. We're all very happy about that. Unfortunately, however, with dry macular degeneration, there has just been a relative lack of therapeutics until recently. And I often get the question in my clinic, why? You know, why do we not have good therapies at this point? And the answer is that it is an incredibly complex disease process. And I was reminded of that so much more as I was preparing for this discussion. It's heavily genetically influenced, and there are dozens of genes that play a role in the development and progression of dry macular degeneration. Obviously, there's also environmental factors, some of which are modifiable, and we do our best to modify those. But ultimately, these factors lead to oxidative damage within the tissue and complement activation, which is what the majority of our therapeutics are focusing on right now, and what we're going to talk about pretty in depth in this discussion. So this is a kind of complicated slide here. We're going to step back into our basic science, years of medical school, and talk a little bit about our immune system. The complement system or our immune system is heavily dependent on these complement factors, which are ever present in our blood plasma, created by our liver. There are several of them that create this cascade of an immune response. So our immune system is incredibly intricate. And its job, obviously, is to ward off pathogens, to remove cellular debris and waste products. And there are several ways it goes about that, but the very basic way to describe that, I'm going to go back one more here just to bring that back in, is through a couple of words that you see up there: opsonization, phagocytosis, and ultimately at the bottom, cell lysis. And inflammation. And it accomplishes this by using so many of these proteins that initiate this cascade down to eventual cell lysis. So just as a review for some of these terms, phagocytosis, we remember that, right? That's a cell eating a pathogen, right? That's easy. Opsonization, I had to review this. I didn't remember what that word meant when I was first looking into this. That's essentially these pathogenic cells being targeted or just, I guess, the signal that this is a pathogen. We need to eat this. I envision it like sprinkling a little seasoning on whatever it is, and the macrophage or whatever the cell says, that looks good, I'm going to eat it, all right? Further down the cascade, things end up in cell lysis, and the way that is performed is through these porin complexes that are formed that actually are inserted into the pathogen cell wall, leading to essentially exsanguination of the contents. It's pretty amazing and kind of savage when you think about it. And of course, inflammation is a promoting factor for the immune system here. Now, there are three traditional ways in which this process is triggered. The classical pathway and the lectin pathway are, I think, for me, a little bit more easy to understand and grasp because we deal with these things. These are antibodies to specific antigens that then trigger the pathway. But what is a little bit more confusing for me, at least in my mind, is this alternate pathway. And that is what the majority of geographic atrophy and dry macular degeneration is, or seems to be the basis of most of these things. So this is a much less specific pathway of immunity, so the body does not have to have an exposure to create the antigen-antibody relationship, but rather utilizes these complement factors that are all present to stimulate the same process. And so this, again, this is a very busy slide, but we will refer back to it throughout our discussion of the therapeutics to kind of see where along the cascade these drugs are targeting. Another great, I thought, illustration, if it'll go forward, maybe. There we go. Is the same slide. You see the one on the left, and then on the one on the right is just basically the same thing, but with a superimposed retina underneath it, right? So you can kind of see this cascade going through the retinal layers, the same opsonization, phagocytosis, and eventually the membrane attack complex porin, unfortunately, in the RPE cell. So hopefully that kind of makes it a little bit easier to comprehend what's going on here. So let's talk about complement inhibitors and how they are being utilized and impacting our current treatment and therapies for dry macular degeneration, and specifically geographic atrophy. Some of these are specifically lampalizumab is a historic one. The other two are more current. But we'll start with the history, okay? And this is just another way to illustrate the difficulty of that we've been going through to try to figure this out. Lampalizumab was a big deal when I was in fellowship. They were all talking about this. This is going to be the next great thing. It was an intravitreal injection that was being utilized to, again, look at slowing down the growth of geographic atrophy. And in phase 2, it looked like things were going to be great. So fast forward, phase 3, the Chroma and Spectri studies eventually showed that there was no meaningful difference in the growth of geographic atrophy versus the sham treatments. And this was a big deal. That was about 2018 when that came out. And I remember the rah-rah, it's going to go, it's going to happen, we're going to have something. And then all of a sudden, you know, despair. All right, well, we're back to nothing again. Great. So that was a big bummer. But fast forward to current and Pegcetacoplan. And so what this is a complement factor C3 inhibitor. So you can see I put little X's. I didn't point that out. The other one is a factor D inhibitor. That was lampalizumab, ineffective. Pegcetacoplan is a factor C3 inhibitor. A little further down on the immune cascade, and was evaluated in the phase 3 Oaks and Derby trials. So these, we'll go a little bit over what those show, but they, a little bit about the design, because it is important to know the design of these studies, because they're a little bit different. For Pegcetacoplan, they looked at both monthly and every other month injections, and their primary endpoint was to measure, just like the others, the GA growth versus the sham. Another important point to point out about this is that it did include both central foveal geographic atrophy lesions and the non-central lesions. What we do know is that the non-central or parafoveal lesions tend to move faster. and are obviously less visually problematic, whereas the center involving, that tends to be that last little island that you see in a lot of these patients. That seems to be the slower moving lesions, but of course more visually problematic for the patients. Very important to note that difference between these studies, because and we'll refer back to that in a little bit. All right, so let's look at the results. So the OAKS study did, in fact, meet its primary endpoint at both 12 and 24 months. It did seem to have an influence on geographic atrophy growth over time. And, you know, the commonly stated statistics is roughly 20%. All right? Derby was their other study, their sister study to the OAKS trial. And at 12 months, the first year, it did not meet the primary endpoint. But at 24 months, there seemed to be a more bending of the curve to get to a statistically significant impact in the growth of geographic atrophy. And when they pooled the 12-month data, it did still show a significant difference between the two. This ultimately resulted in FDA approval of this medication in February of 23. So that's the good, okay? So if that's the good, what's the bad about the studies? Well, if you look at that 30% dropout rate, that is significant, okay? And this is in a clinical trial where we are chasing down these patients to come and get their treatments. 30%, and that's in the treatment group, by the way. So that has potential to skew some data for sure, and that is very high. So I think that cannot be understated. There's also a increased risk of CNV formation or conversion to wet macular degeneration, which we are seeing in general in all these medications, about fourfold. There was a small NAION risk. We don't really know exactly why that is. Some people postulate that it has to do with the pressure increases with these medications. I don't know. We've been injecting 0.1 of cc's of things in the past without as much problems before. So hard to say, but there was none in the sham. I think one of the biggest things is that there was no improvement in these functional measures. So their visual acuity between the two groups did not change. Okay, they looked at various different functional measures and none of them were significant. So those are kind of the bad. Now, if you look at the good, bad, what's the ugly? Well, the bottom one here, as we know, and we all heard about, that there's hemorrhagic occlusive vasculitis did present itself after FDA approval. It was not seen in these OAKS and Derby trials, but as it was becoming more utilized, it did rear its ugly head, unfortunately. And we have some pictures of what that looked like. It's a very scary looking thing. I am thankful I've never seen it, but I know people who have, and in general, these folks unfortunately did not regain their vision. So these are from the actual publication, I think in Retina, after this came out. So let's go on to the next medication, Avacincaptad pegol. I hope I'm saying that correct. I've heard Avacincaptad pegol as well. I don't know. Also known, I don't know if I'm allowed to say this, also known as Izervay. For fairness, Pegcetacoplan is also known as Syfovre. This is Izervay, just for all of us who have a hard time remembering these. But Avacincaptad pegol, it is a complement factor 5 inhibitor, so it goes even further down the immune cascade tree. It was evaluated in the GATHER1 and GATHER2 trials, and importantly, it did not involve any foveal center involving GA. It was non-foveal center, so it's a big difference between the two studies. This also looked at only monthly injections for the first 12 months. So the last one was every other month or monthly, and they seem to have similar outcomes. The monthly, this is only monthly, okay? And of course, looking at GA growth as their primary endpoint. And it was met in the groups at 12 months, as far as the primary endpoint was met there. And again, this led to, I hope I don't overdo it, FDA approval about 6 months later in August of 23. Again, about 18%, 18 to 20% seems to be the magic number that we're looking at for a lot of these medications in a perfect clinical trial setting. All right, so that's good, I guess. Let's look at the bad, as we have to. They had about 11% dropout rate. Now remember, this is a 12-month trial, not 24-month. Doubly increased risk of wet AMD in 12 months. They did not see any NAION or any occlusive vasculitis reported in their studies, and to date, as far as I know. But again, at the bottom there, you can see there, again, there's no visual benefit that we've been able to identify or measure. That's current. Now this is as current as we can get, okay? So both of these studies have extension trials. This is the GALE study, which is Pegcetacoplan, 36 months. This is all population, non-subfoveal and subfoveal, seems to maintain approximately the same effectiveness. One thing I'll point out, that dotted line is a projected sham line, okay? So they're not measuring sham anymore. They're just sort of projecting it. There's potential issues with that, but it does seem to maintain some efficacy here. They also responded to the non-subfoveal design of the other medications, and they've measured that, if this will move forward, to a non-subfoveal, which may have a little bit better efficacy, which makes sense, right, like we've talked about. For the GATHER Avacincaptad pegol extension, we're at about 24 months. None of these have been published. These are all being presented at the various meetings. And similarly, what they did is they split the treatment group into two, continued monthly versus every other month. Both of them seem to be maintaining approximately 20% or so. Interesting, the every other month seemed to do a little bit better than the monthly. I don't know why that would be, but that's just what the data is showing currently. It's hard to extrapolate based off of that. So that's exactly where we are. Briefly, let's get into some emerging therapies, okay? And this is a tip of an iceberg. There are so many things happening in the realm of dry macular degeneration. These are just a few that I'm familiar with, seen along the way, and are involved with in our practice. We just closed out our golden study patient population. This is a factor B inhibitor, kind of high up on the cascade. But the interesting thing about this, as well as the Regeneron study, these are subcutaneous injections rather than intravitreal. And I think that's very appealing. Getting away from sticking stuff in eyes is always a good thing. And the Alexion study, a factor D inhibitor, it's in phase 2, is an oral inhibitor. So we shall see where this goes. Factor D failed with lampalizumab, as you may remember, but we'll see how it affects here. This Archer and Arrow study I thought was interesting. We're not involved in this one, but it is actually attacking or blocking the classical pathway rather than this alternate pathway up at the top, as you can see. So it's a C1q inhibitor. It is intravitreal and is in phase 3. So many things to look forward to within the realm of complement inhibition. And the last thing I wanted to point out, this photobiomodulation. Remember that term. I think that we will hear more and more about this. There have been some really interesting studies and publications using certain wavelengths of light at certain luminance where patients are looking at it for a specified amount of time. And this light site, they just completed their 3rd study of 100 or so patients, kind of small, but actually showed visual improvement even at an earlier stage than before these things get to geographic atrophy. And I really think that is, I'm hopeful. I don't know, because by the time geographic atrophy starts, maybe we're a little bit too late. And that's kind of what we have. So in conclusion, I think, you can tell I'm not thoroughly excited about some of the therapeutics we have right now, but I don't want to discount how significant the advances are. These are significant advances. We've tried and failed so many times. But let's point out the other things. There were no visual differences between these populations in the studies, and we need to remind our patients of that. The risk profiles are certainly concerning, as is the treatment burden, and especially when you compare it to the relative small benefit. So therefore, you really have to talk about this with your patients pretty in depth and educate them well and select them carefully. And obviously, we know more research is necessary. So thank you very much. I have one more slide that I would have been remiss if I didn't take this advantage with a bunch of Oklahoma and Texas fans to point out that I am a fan of the current national championship team. It's my wife and me at the Rose Bowl. She's an Alabama fan. We're still married, but it was a little dicey there for a minute. And then my kiddos there in the middle there, that you can see how excited they are about dry macular degeneration too. Yes, absolutely. Any questions, please?
So, as a comprehensive ophthalmologist, I guess one of my questions is, from your perspective, who would be the ideal patient to get either Kaiser or
Yeah. Yeah, so the question is, who do we think is probably the ideal patient to receive these? So I am utilizing these medications. And the patients that I'm utilizing it in are the people who've already lost one eye to geographic atrophy, and they know, and this one's, you can see it happening, and it is worsening. Because we actually have something that may impact their course, and they're trying to hold on to it. That being said, you have to be very cautious. I spend more time talking about dry macular degeneration than I ever thought I would. And what I would say from what I'm hearing and the way I practice, I will, with concern for a bad inflammatory complication and potential loss of their good eye, I'm injecting the bad eye first. Because if it's going to happen, at least you're losing their already bad eye. And it seems that all the horrible inflammatory reactions are after their first dose. So you can have a little more confidence that, okay, we've at least tested it on your bad eye. Even though I don't plan to treat that eye going forward, let's move forward with your other eye. So that's how I'm utilizing it. I think that seems to be pretty standard across the board from what I've been hearing. Yeah, another, if you look at patients that are not going to get a benefit for 2 to 3 years potentially, you might want to avoid using this in a 95-year-old, right? Because they're never going to see the benefit probably. They may live to be 105. I don't know, but I'm maybe selecting them a little bit younger that have a longer runway, and maybe a little bit earlier before it's subfoveal involving, because after that I don't think they're going to see much improvement or benefit. Great question. Any other questions? Yes.
Have they looked at any correlation between that genetic markers they can be for this patient population that shows some improvement? Particularly with these patients with some of the oral and sub-Q therapies, and see if there's a correlation between how they can do those things.
I don't know if I caught all of that. I think the question is have they looked at genetics specifically and the correlation between the growth of the lesions, the effectiveness of these medications? I'm sure somebody is. I don't know of any that has been significantly reported yet. But I think the genetic testing is becoming a bigger and bigger thing as we're becoming more capable of it. So I wouldn't be surprised if that becomes a bigger thing.
Fine.
Thank you. Thanks, guys.